Hello, my name is Rafeeque Bhadelia. I am a neuroradiologist in Boston, and today I'll be talking about how to assess headache in Chiari malformation patient using real-time cerebrospinal fluid flow imaging, a newly developed technique that we are using, which is different from the CSF flow imaging performed routinely. This study was supported by a grant from Conquer Chiari Foundation. I have been working on imaging the CSF flow in Chiari patient for quite some time. As you can see here, this is our first publication in 1995 in Radiology, which dealt with cerebrospinal fluid flow waveforms analysis in patients with Chiari malformation by means of gated phase contrast MR imaging velocity measurements. At that time, we showed how it could help demonstrate abnormalities at the CSF flow and differentiate Chiari patients from normals, and also show how the benefits of decompressive surgeries can be assessed using the CSF flow. The overall goal of this new project, which based on the shortcomings that we observed on our older method, was that we wanted to develop a non-invasive MRI method that differentiates between Chiari 1 malformation patients who can and who cannot benefit from decompressive surgery. The method assesses the response of CSF flow to cuffing and Valsalva maneuver, which are known to produce headache in Chiari patients. One would like to review first what is a Chiari malformation. As you can see, here on this slide, particularly on the right, on the left side, this is the skull base, and this, if you draw a line between this and this point, this is called the foramen magnum. Now, normally, as you can see, particularly on the right side, this is a normal patient. If you draw a line at the foramen magnum, the cerebellum or this structure is above the level of the foramen magnum. As you can come back to here, you can see that the cerebellar tonsils are projecting below the level of foramen magnum, and foramen magnum is the area which separates the head and the spine. So when the tonsil extend from the head to the spine, that is where we could call it Chiari malformation. Now, generally it is agreed that about 5 millimeter or more cerebellar tonsillar herniation would meet the definition of Chiari malformation, but there are some exclusions to that, and I'm not going into the detail of it because they are not that common. In the middle, one can see a patient with Chiari malformation where the cerebellar tonsil, the MRI scan here shows the cerebellar tonsil extending below the level of foramen magnum. Now, one can also see that if you go back to the right side where the normal patient, that this bright signal that we see is the CSF extending from the head to the spine, which is contiguous in a normal patient. But in Chiari patient, as you can see, the CSF is not contiguous between the head and the spine, which constitutes the CSF flow obstruction. And we know that most clinical findings in Chiari malformation are attributed to obstruction to the CSF flow between head and the spine, and also due to crowding and compression of the hindbrain or this area of the brain at the foramen magnum, because as you see, this is a small area, and when all these neural structures are crowded here, that can produce compression and symptoms. There are many findings or clinical features that the Chiari patients, the symptoms that the patients would complain, and the findings that the doctors can assess. But there are two major clinical facts. One is headache, which is seen in 85 to 90% of the Chiari patients based on the statistical data available to us, and syringomyelia or cyst in the spinal cord, which is seen in about 30% of the patients. Now, headache in 2/3 of the patients report headache to be worsening after activities such as cough, Valsalva, laughing, etc. But in only 1/3 of these patients, the activities-associated headache is typical. What is a typical Chiari headache? A typical Chiari headache is a transient activity-associated headache. It is temporarily or with time related to activities such as coughing, Valsalva, sneezing, laughing, bending forward, or exercise, and it is of short duration. Now, this is the definition coming from the International Headache Society. So it is short duration, like less than 5 minutes. So the person does not have any headache, then they cough or Valsalva or do some activity, they have headache. The headache lasts for 5 minutes, but it could last a little longer, maybe 10 minutes, 15 minutes, and then it disappears, and the person is normal again. Typically occipital or suboccipital in location, so in the back of the head, but can be also in the front of the head or the side of the head. But again, it would be short duration and related to the activity and not happening when the activity is not there. Activity-associated headache also are commonly known as cough-associated headache or Valsalva-associated headache when you are reviewing any of the papers or other findings that you may see during the presentation here or in other places. So it is a term that to be remembered. They are interchangeable. Cough-associated headache is the same as Valsalva-associated headache, but Valsalva-associated headache generally means that you get the headache with Valsalva. A typical atypical Chiari headache is different. It is constant, localized, so like back of the head or occipital, or generalized headache, like a constant daily headache, that may be exacerbated by cough. Transient or constant suboccipital headache, also that is not cough-related, could be called an atypical headache. And finally, transient or constant localized non-occipital or generalized headache that are not cough-related could be called atypical Chiari headaches. Let us review what is the cause of headache in Chiari malformation. And as we mentioned before, in patients with Chiari, a typical headache is caused by CSF flow obstruction at the foramen magnum. And obstruction of the CSF flow, as you see here on the left side, this is a normal person. The person coughs. During coughing or Valsalva or bending, the CSF pressure in the spine increases and pushes the CSF to the head. And after the cough and Valsalva have passed, the CSF, the extra CSF that has gone to the head, would like to come down and can easily come down in a normal person because this area between the head and the spine is widely open. However, in a Chiari patient, like a ball valve mechanism, when the person coughs, the CSF can go to the head because the brain is lifted up. But when they have finished the cough, CSF is trying to come down. The brain also tries to move down with it and further obstructs the foramen magnum here, and the CSF flow is decreased. As you can see by the arrow size, the CSF would be expected to be decreased below the level of foramen magnum after coughing in a typical Chiari headache. What is the clinical significance of typical Chiari headache? A typical Chiari headache or a cough-associated headache is an indicator of clinically significant Chiari disease. Means that there is real and significant obstruction at the foramen magnum. A typical Chiari headache is an indicator of high rate of surgery-related success, which is reported by the patient. How imaging can help in clinical decision-making in Chiari malformation? We know that a large number of patients with Chiari headache report worsening with activities such as cough or Valsalva. However, many of these patients don't fit the description of typical Chiari headache, but there is no objective method or a method that clinicians can rely, not dependent on the patient presentation or clinical history, to determine if headache is due to CSF flow obstruction. Currently, clinical decision-making for surgery is in a Chiari patient with headache is entirely based on subjective patient reporting of symptoms and the philosophy of the surgeon. So one surgeon might think that the patient's report is not typical for a Chiari headache, the other surgeon might think of it. Imaging can contribute to this by objectively showing expected changes in CSF flow. So imaging can show that there is CSF flow obstruction after coughing or Valsalva, and then both surgeons can look at the same thing in light of that finding. What is the rationale for imaging in Chiari malformation? Imaging helps in the diagnosis of Chiari and to determine the severity. Imaging can directly demonstrate obstruction to the CSF flow at the craniocervical junction or between the head and the spine. Different methods of imaging can be employed in Chiari. One is called the anatomic imaging, which is like a routine MRI, which just shows the images of the brain and the spine. And then the other methods are physiologic methods, or they show the CSF flow itself. A routine cardiac gated phase contrast that I mentioned that we use since 1990s is available on most scanners that can be used, but we found that it is not as sensitive as one would expect it to be. And in order to improve on that, we developed what is called a real-time phase contrast imaging technique, and which can be used with a patient while in the scanner can cuff or do Valsalva, so that we can in real time assess the changes of the CSF flow with those response. It is still a research method, not widely available. What we would expect from this imaging in patient with a typical headache, MRI should show evidence of obstruction to CSF flow, and there should be decreased flow after cuffing below the foramen magnum. And how do we know that? We know that because of the previous experiments performed by neurosurgeons in the late 70s and 80s based on the pressure measurements in the head and the spine. Nowadays, we do not perform those invasive pressure measurements, and we would like to develop a non-invasive technique such as the MRI-dependent technique, which could provide us the same information. A typical cuff-associated headache can be suspected on anatomic imaging. Like if you look at this patient here, on the left side, on the left side, there is a Chiari malformation. There is tonsillar herniation below the foramen magnum. There is no crowding of the neural structures of the foramen magnum. There is no obstruction of the CSF. And as you see here on this side, there is tonsillar herniation, but there is crowding and there is interruption of the CSF between head and the spine. Now, we found that in tonsillar herniation greater than 10 millimeter, generally, these people have a high likelihood of having typical cuff-associated headache, but the sensitivity of that is not that high. We also looked at the routine phase contrast with the cardiac gating, the one that we've been using for a while, and had some observations based on that, and we were able to see that when you are able to see it bidirectional flow just below the level of foramen magnum, like a color of black while everything is white or blowing downwards, would give us an idea that this person could have a typical cuff-associated headache. However, again, the sensitivity is not that high, although there was a little reasonable specificity for that of 86%. So what are the problems that we were facing? Why were we thinking, after using so many years of routine cine phase contrast, that this is not a very good method to use? The routine cine phase contrast method is acquired while patient is resting with imaging time of between 3 to 7 minutes. You can shorten it, but still it could be about 1 to 2 minutes. It is not possible to assess CSF flow while the patient is cuffing by routine PC method because of the long imaging time. Many Chiari patients are not really symptomatic while resting, so the cine PC technique can only give us the flow when the patient is actually, the flow is related to the heart beating, but not related to the respiratory movements like cuffing or Valsalva. And there is also another problem, and that is wide variation in CSF flow between the patients. Because we don't have very large number of studies like such as we can compare that X amount of CSF flow below the foramen magnum is typical and would produce headache. It is not possible to do that because of the wide variations between the patients in the flow. And unless we measure like hundreds of thousands of patients, it is not going to be easy to assess that. So like for example, a clinician can compare the blood pressure between patients and say, okay, you have 90 millimeter of mercury, you have a high diastolic pressure. We cannot do that with the amount of CSF flow very easily. So how to address that problem? We can use a real-time flow imaging technique with MRI. So the real-time is that the patient is not linked to the heart. The flow is not linked to the heart, but you can just freely assess the flow. And then while you are assessing the flow freely, use a physiologic challenge such as cuffing to assess the CSF flow, both in resting and after cuffing. And you can compare the resting to after cuffing and see use the patient as their own records. And this is going to be similar to the pressure studies used by Williams and other investigators in the past at the NIH. So this brings us to the objective appraisal of headache in Chiari malformation with real-time CSF flow imaging. Now the technique that we are using is called the pencil beam imaging, and the method is called pencil beam because like a box, it is set up at the craniocervical junction or between the head and the spine. And you can see it is here, it covers the entire area of CSF flow. And it can record both velocity and flow of the CSF without producing images. So there are no real images with it. We use this anatomic image to set it up. But the information that we get out of this particular sequence is only the flow and the velocity. It also records the heart rate and respiration at the same time. And we can measure several areas, like routine CSF flow imaging that we use with phase contrast can only use at one level. Like, for example, at this level. With this method, any level in this box can be assessed at the same time. So how do we employ cuffing or Valsalva during imaging? We do a total imaging time of about 90 seconds to 100 seconds. The subject is asked to breathe quietly for about 15 to 20 seconds after the machine starts. Then they automatically, forcefully are instructed to consecutively cough 5 to 6 times forcefully without moving their head, and then breathe quietly for the remaining imaging time. So here is the display of that CSF flow with the real time. What does it show? So on the left side, we see an anatomic image, which we use to set it up. This is the area, the red line, where we have measured the flow. And the flow on the top is at a phase image. Like that is the image that comes out. There is no real image, but just the velocity image. And in the middle, out of this, we have created this waveform. So each waveform here is the beating of the heart. Whenever the heart beats, the CSF pulsates in the head, and you can see that here in the resting phase. This is the first 15 to 20 seconds. Then the patient coughs violently without moving the head, or forcefully, I would say rather. And then after the cough is over, the post-cough period, as you can see, the height of this waveform has considerably decreased for a certain period of time, about 5 to 10 seconds. And after that, the patient actually restores the waveform size like the resting. Although the patient may develop complaint for 5 minutes, the flow disturbance is very short. It's about 5 to 10 seconds or 20 seconds, depending on the patient obstruction. In the bottom part, you can see the waveform of the respiration. Here, the patient is quietly doing respiration and then suddenly coughs here. So that that is the movement related to the cough. And again, the patient is breathing quietly. The heart rate changes are also seen. Suddenly the heart rate goes up and then comes back, while coughing, immediately after coughing, the heart rate also goes up. So here are the two examples. One example on the top is a patient with typical cough headache, a tonsillar herniation of 10 millimeter. So, and the bottom is the patient without cough headache and tonsillar herniation of 11 millimeters. So the tonsillar herniations are of the same size. However, if you see the top part where the patient with typical headache, you can see a normal waveform in the resting, then coughing, and then you can see a prolonged decrease, about 20 seconds, of the CSF flow. Now we can measure that, enlarge it. You can measure the height of the waveform, and you can also shed the area under the waveform, and you can measure those to give a number to it. And as you can see here, this is the height of the waveform before in the resting and after coughing. It decreased by almost 75%. And when you look at the area under the curve, it decreased by about 82%. So there is a considerable decrease from the resting to after coughing, which comes back to almost normal on relaxation when the patient has stopped cough after about 60 or 30, 40 seconds after the coughing. It doesn't happen the same way in a patient without typical cough headache. You can see here the resting, coughing, and after coughing, the decrease is not very not very much. The waveforms are of similar size. The area under the curve is almost similar, and the relaxation is almost similar. So there is hardly any change. Now, this is actually a very good example of, you can see with a typical and atypical headache. So our observations based on these, several of these patients is, patients with typical cuff-associated headache have greater than 50% decrease in height of the waveform of the CSF and the area under the curve after cuffing compared to the resting. And in patients with atypical cuff-associated headache, there is minimal to no decrease in the height of the waveforms or the area under the curve of the waveform in after cuffing compared to resting. There are several limitations, though, that we need to point out. At present, imaging only possible on Phillips magnet. Other major vendors have no interest in developing this technique. That is kind of discouraging, but we have been trying to have General Electric and Siemens develop this method. Presentations from the patients would be quite helpful with that. The reason that right now if we can use it on several of the vendors, many of the researchers can use this technique and can confirm our findings and can also help do the large-scale studies. Pencil beam sequence still needs to be run in a research mode, even in the Phillips magnet. So it is not freely available to be used on any clinical magnet. So in order for us to use this, we have to have a research contract with the company, and we can't use it without the research contract. So in conclusion, real-time physiologic measurements of decreased CSF flow after cuffing relates to typical cuff-associated headache in Chiari, and pencil beam technique can be used as an objective tool for assessing Chiari patients with headache. That is our conclusion. A prospective study, though, one needs to understand that a prospective study of Chiari patients with headache, a large-scale study, is needed to investigate whether typical Chiari findings correlate with better surgical outcome compared to those without this finding. And again, as I said, we need to do many patients on different vendors to be able to understand this, which currently is not possible to do. Thank you very much.